Assalamu alaikum ji. Welcome to the Bayer Symposium on optimizing patient care in retinal diseases. I am Dr. Aziz Jan Bashir and I'll be moderating this session. So I'll start with introducing the chairs of the session. Professor Tariq Aziz, who is not yet here, but he'll be joining us soon because he's busy in another session. Professor Khalid Waheed, Major General Dr. Mazhar Ishaq, Professor Rashid Kamar Sab, and Professor Nasir Saeed Sab. The panelists who will be talking about their experiences and the various topics related to the subject would be Dr. Qasim Latif, Dr. Amir Awan, Dr. Tariq Khan, Dr. Tariq Khan Marwat, and Dr. Ali Afzal Bodla. So we'll start with a discussion on how the our worthy retina specialists here who are chairs and panelists, what are their experiences in managing patients on aflibercept. So we'll start with Dr. Amir Aman is, I guess, not here. So we'll move to Dr. Tariq Khan Sab. Sir, Mike.
Well, I'm using this aflibercept idea for the last 4 years. Previously, I was using this Petrozza, and I wasn't using bevacizumab for the last 6-7 years. Not because of that problem of endophthalmitis, but I was seeing that it has become non-effective. There was no effect of Avastin on patient. I discussed with Dr. Qasim also. So I shifted this to Petrozza and then aflibercept. Petrozza has a different mechanism of action.
Sir.
Aflibercept has a different mechanism of action. It combines with the receptor on the blood vessels, which is causing the main problem, the VEGF receptors. And the FAB component, it combines with the VEGF itself. So it's a dual function.
Okay.
And it also inhibits the placental growth factor, which is also important in the development of DME and other causes. Up till now, we have only two factors known, NH2, which is by the other company, and placental growth factor by this one. There are multiple factors. I think maybe in the future will come.
It's a very complex mechanism.
If you see that.
Yeah.
But with aflibercept, I've seen immediate decrease in the amount of the edema.
Yes, sir.
And the patients are very happy after first 2 injections, and they go for the third. But at the same time, I'm talking about the DME. You have to consult the patient of the control of diabetes, because all those products are being produced because of diabetes. And if they don't control it, I mean, you keep on giving the injection, which is not reasonable. So you have to consult the patient that you have to control your HbA1c to 6.5. You have to control the renal function test and all that kind of stuff. But immediately, I have an experience. Diabetes coming more common in the young patients also. And they do not know they are having diabetes until unless they develop a kind of a complication like I've seen proliferative diabetic retinopathy, DME in very young.
Yes, sir.
And वो कहते हैं हमें तो पिछले साल ही पता चला कि हमें डायबिटीज
सर अक्सर विट्रियस हेमरेज के साथ प्रेजेंट करते हैं, आप इन्वेस्टिगेट करते हैं तो
बिल्कुल करते हैं. And secondly, I remember I've also given an example. There was a young girl who had proliferative, I did a PRP, and then कहते डॉक्टर साहब मुझे इतना कर दे कि मैं अगले महीने मेरी शादी है तो मैं अपने आप को देख लूँ. And I think that worked very well earlier. And I gave her 3 injections and did a PRP and then consult the patient controlling, and I think she's fine. So immediate reduction in the DME, immediate improvement in the vision is much more with aflibercept as compared to the other ones.
So what, like you said, you started using them 4 years back.
5 years back.
5 years
that
back.
Was the price. One was the thing. Petrozza was slightly cheaper as compared to Eylea. And patient had response, but then when I shifted to aflibercept, see the result, I'm not using Petrozza anymore.
Sir.
Although they've increased the price, but still I'm not using. जब से प्राइस मैंने वो नहीं इस्तेमाल करा. I'm strict.
So it's still cheaper मेरे ख्याल से.
It's still cheaper as compared to if you do that. But the And in CNV, there was a patient who comes to you, who came to me from Bahrain.
Sir.
He's the importer of this meat. He's very happy with this, and वो कहता है डॉक्टर साहब अच्छा मैं पहले टीका आके लगवा रहा हूँ. So I mean this age-related macular degeneration, CNV, they are to be on anti-VEGF for a very long period of time.
बिल्कुल
उसको जब भी कहते हैं नज़र कम होगी डॉक्टर मैंने टीका लगा दे, तो उसको OCT भी नहीं करवाता, वो कहते टीका मुझे लगा दे डायरेक्ट.
समझ आ जाती है सर
वो
उसको.
इम्प्रूव करता है. एंड सेकेंडली आई ऑल्सो ए पेशेंट जो ये लगवाता था, वो OCT में उसका कुछ नहीं है लेकिन उसकी विजन डिस्टर्ब थी. जब उसको इंजेक्शन लगाया था ही इम्प्रूव्ड. सो आई थिंक OCT is a second procedure, I mean diagnosis. Vision of the patient is the most important thing.
बिल्कुल सर. सर वो आता ही आपके पास बेसिकली
Vision के लिए
वो हॉस्पिटल वापस इसीलिए आता है कि
उसी
उसको
के लिए
प्रॉब्लम हो रही है
आपको
सर.
ये करें and it has a very good effect.
थैंक यू सर.
Thank you.
तारिक खान मरूद सर.
Thank you very much. Well, I'm injecting anti-VEGFs. Overall, anti-VEGFs started definitely with the Avastin. Since October 2006, as far as I remember. So, तकरीबन 18 साल हो गए.
18 साल.
And there is no doubt about कि anti-VEGFs जो है वो mainstay treatment है और effective treatment है. When I'm choosing a drug for any disease, I think I will always keep three things in mind. One is safety, another is efficacy, and third is cost effectiveness. So we started with Avastin because at that time the other competitors were not available, or if available, they were quite costly.
Yes sir.
There was a lot of cost difference. Regarding safety, I think aflibercept is in the market maybe for the last 10 years now.
Sure.
So इसकी जो ये safety है that is quite established. I think millions of injections have already been given to the patients. So there is no question about the safety. On the other hand, previously as we were using Avastin, तो उसकी safety में कई दफ़ा कुछ pitfalls ऐसे आ गए
बिल्कुल सर.
कि now we are reluctant to use it. So the second thing is efficacy. I think efficacy is also well established. It's VEGF trap. Its binding affinity is very good, prolonged, and that is the reason you get extended treatment intervals. बाज़ लोग initial 3 injections के बाद 8 weeks पे shift हो जाते हैं, बाज़ 12 weeks पे shift हो जाते हैं, and it's doing well. So efficacy is also very good and very established. Third is cost effectiveness. तो इस वक्त जो competitors हैं मेरे ख्याल में उसको अगर देखा
सबसे
जाए
cheap
तो
जी सर बिल्कुल.
relatively cost effective भी है. So it's now becoming the number one choice for many of us. I think.
So do you still use bevacizumab or you have stopped using it?
Yes, I think because I'm also working in a government hospital, so we see a lot of patients who cannot afford even. So हम आज भी Avastin लगाते हैं और पता नहीं कि ये लीगल है या इलीगल है लेकिन लगाते हैं.
Legal है सर. Legal.
So because most of our patients still cannot they cannot afford the costly drugs, so hospital setups में especially Avastin is still there.
Sir, उसमें when have you ever had a chance कि जिसमें you have been using bevacizumab and there was little to no response and you switched, and do you have any experience of that, sir?
Yeah, definitely yes. I think there are pretty good number of cases. There is a significant percentage of patients who we don't know whether there is a drug resistance or there is maybe a delayed response. But there are some patients who do not do well with Avastin, but they do better with Eylea. And I mean,
Sometimes, sir, even when you inject your first injection and they
Yes.
in a week they improve sometimes.
yeah,
I have
definitely.
seen a few
Yes.
cases
Bilkul.
where I've been giving them bevacizumab for 4 or 5 injections, and they would slightly improve. And the moment you change,
You are
they
very
just
right.
improve significantly.
Yes, and I think there is also probably another reason as well कि इसकी जो binding affinity है
बिल्कुल सर.
that is also extended. It binds with VEGF-A, VEGF-B, and the placental growth factor as well. So probably three prongs effect है इसका.
बिल्कुल.
So that is probably the reason as well.
No
So
problem. Thank you, sir.
pleasure.
Dr. Amir Awan, sir. Sir, would you share your experiences, sir?
Yeah, aflibercept, I think it's a very good product, and the good thing is that it's acting at the multiple receptors. So we know that it inhibits placental growth factor, VEGF, all forms, and it really helps in the patient. And the good thing about is that you can extend it. So what I have seen, I have extended up to like 8 to 12 weeks in wet AMD. In diabetic patients, yes, initially I give the loading doses, but after that, those loading doses, if the fluid is absorbed, I don't require any further injections in diabetic patients. So
So how is your experience with extending, like for example, if you are maintaining the patient on 8 or 12 weeks, how is the response, sir?
Yeah, I think it's very good. Especially I will talk about here in wet AMD patients.
Sir.
So in those patients, like I have got quite a few patients in which I have extended up to like 16 weeks. So which again, if you look Vabysmo, their main point is that 16 weeks you will not have the fluid. So same thing we can get with aflibercept as well. And I think other thing I would like to highlight here regarding the angiopoietin 2 blockage, which Vabysmo is claimed to be. So, but again, we are not exactly sure that angiopoietin 2 is definitely important in causing the retinal vascular diseases or aggravating it. And other thing is that if you look at the rabbit model, vitreous fluid, if we compare between aflibercept and ranibizumab and bevacizumab, we can see that they all reduced angiopoietin 2 levels. And especially if you look at aflibercept, that reduces more. So more potent response we start getting in 26 days, and it keeps maintained up till 56 days. So that again, it is wonderful drug regarding that.
Sir, can we correlate the two? Because we had studies like Ruby and Onyx, which used anti-Ang2 and aflibercept alone. They compared it, and there were no significant difference between the two. So again, like you said, all anti-VEGFs reduce Ang2 levels, be it bevacizumab, ranibizumab, aflibercept, or faricimab. So does it really matter that because yes, it has a role, Ang2 has a role in the vascular permeability, the new vessel formation and all that, but does it has any effect clinically speaking, sir, on the, is it proven that if we reduce the Ang2 levels, would that be of any significance?
Yeah. I think I'm glad you mentioned about Ruby and the Onyx trial, which Ruby is about diabetic macular edema and Onyx is about wet AMD patients.
Sure.
And what they have seen is they used anti-angio2, that's a nesvecumab, which is much more potent than faricimab.
Yes, sir.
And what they have shown that if you combine it with aflibercept or you just give the monotherapy of aflibercept, there is no difference at all in best corrected visual acuity, even central retinal thickness. They all remain same. So to be honest, what they have shown from this study, there is not much difference at all. And I think there is another important thing is there is another study in which ranibizumab and Vabysmo has been compared about Avenue trial, and what they have shown, if you give monthly injections of ranibizumab, you get the same response that you get with the
Yes, sir.
Vabysmo. So I think main difference is 16-week things, what Vabysmo claims to be. So we don't know yet because in Pakistan we haven't used, but if we discuss with the colleagues abroad, they have shown that it does. But as I already mentioned with aflibercept, yes, we can extend it, and we can go up to 16 weeks.
Sir, but the trials that they had, the Lucerne and Yosemite and all that, what they did was they would increase the interval of faricimab, but would not increase the interval of aflibercept. Do you think is that scientifically a good thing to do? Because you could, with aflibercept, as you said, and you practice that you can extend up to 12 weeks. Even some people do extend it to 16 weeks. So wouldn't it be what do you say, honest to do the same thing with both the drugs?
I think you're absolutely right. So what happens when they do trial, what they look at that previously the trial was done, so they just try to compare in the similar way. They try not to compare the clinical outcome. So I think it's fair enough. If we want to compare with aflibercept, we try to compare by increasing their duration as well in the similar way as with the faricimab. And recently I was in Singapore, and there were a few studies they were mentioning about Eylea HD, 8 milligram. That again, and that's again they have shown even with the increased dose that it works fine up till 16 weeks.
Yes, sir.
And I'm sure aflibercept 2 milligram would do the same as well as we are getting with the Vabysmo for 16 weeks.
Thank you, sir. Thank you. Dr. Ali.
Thank you very much, Aziz. Well, before coming back to my experience, ये जो भी हम बात कर रहे थे, I'm going to extend it a bit.
Sure.
Do you know the trials? When we see a trial, it is for two things. Number one, whether it's safe or whether it works. Now, whatever drug we take, every drug works. We know that. So the point is how you decide for a particular thing and how it comes into your practice. It comes on in your practice based on the results that you get from treatment naive patients.
Sir.
अगर आप तारीख देखें तो हम सब के पास aflibercept आने से पहले एक certain pool था clinics में जो कि Petisra पे थे, जो कि Avastin पे थे. So how aflibercept started, and how aflibercept started in the real world. I'm not talking about here, but in the West, it started on उन मरीजों पे which started giving results when we are not getting the results from Petisra or the other drugs. So this is something which is going to determine in real life. Coming back to aflibercept, the way, like my personal experience, it is based on two things. Number one, the treatment naive patients. How we started aflibercept, we had a pool of patients, some were doing fine, some were not doing fine. And then we tried aflibercept and found it that it works better. And this was the kind of paradigm shift, not only in the West, but in fact in our country as well. So more and more people moved to aflibercept. That was one thing. The second thing was treat and extend. With aflibercept, due to financial restraints and everything else, we have been able to extend the time interval. We went to 8 weeks, we went to 12 weeks, and as Amir very rightly said, like it has been 16 weeks in quite a few patients, quite a lot of patients. So these were the two main things that made aflibercept more popular.
Sir, it improves compliance too, sir. एक मरीज को
जी,
हर
जी.
महीने बुलाएं या 2 महीने बाद बुलाएं तो 2
देखिए
महीने
जी.
बाद शायद आएगा भी खुशी से.
Exactly. Do you know, if you look closely, just look at the loading doses that different studies suggest. And if we ask ourselves sincerely, for example, how many of your patients in your clinical pool had a loading dose of 5 injections? Let it be any drug. We are not talking about a particular drug. Let it be any drug. Practically, it doesn't correlate to our country. And this is the reason aflibercept was successful in the past. And this is how the future is going to get determined. Let it be any drug. What is going to determine is treatment naive patients. प्रॉब्लम ये है कि हमारे मुल्क में अब डायबिटिक मैकुलर एडीमा ले लें या किसी हद तक न्यूवास्कुलर एएमडी ले लें, इसका पूल इतना बड़ा हो चुका है, कि इट हैज गॉन इनटू मिलियंस. और आपके पास भी ऐसे बेशुमार मरीज होंगे which are not going to be happy whatever drug you are using. So what would determine is when some of those patients are going to get results, and this is what which is going to determine, and this is what aflibercept did in the past.
Time tested.
So yeah, this was the conclusion.
Thank you, sir.
Okay, thank you.
One thing I would like to add और वो ये है कि there are many things still unknown. बहुत सारे queries ऐसे हैं जो unanswerable हैं. उसमें एक ये भी है कि अगर आप monthly doses पे I mean you know better than me कि आपके पास बहुत सारे ऐसे पेशेंट्स होते हैं जिनको दर्जनों इंजेक्शंस लग जाते हैं.
बिल्कुल.
तो जो सेफ्टी का इशू है जो हम बात करते हैं वैस्कुलर एक्सीडेंट्स की और स्ट्रोक की और एमआई की, तो वी डू नॉट नो. जो एक्सटेंडेड डोजिंग है उसका एक ये फ़ायदा भी है कि जो सीरम वीजीएफ लेवल है वो ज़्यादा अफेक्ट नहीं होगा
बिल्कुल.
एक्सटेंडेड डोजेस.
एक्सपोजर कम होगा तो उस हिसाब से वो भी कम
तो
होगा.
अगर मे बी स्टिल इट इज़ डिबेटेबल, बट अगर वो रिस्पॉन्सिबल है इन एक्सीडेंट्स के लिए तो वो भी आप उसको अवॉइड कर सकते हैं.
That is a factor, sir. Thank you, sir. Dr. Qasim Latif, sir, what do you want?
Assalamu alaikum ji. So my experience with the episode Symp when it came, इससे पहले I had experience with steroids, with Macogen, and with other off-label drugs which we were using, and then we got one FDA-approved drug, and then we got this drug, and the moment जो हमारे chronic patients है, we started using this drug. All of a sudden जो उनका macular edema 300, 400 पे फंसा हुआ था, नीचे नहीं आ रहा था, and then we started realizing कि वो नीचे आना शुरू हो गया. So a lot of patients, I think more than 50 to 60% patients who were chronic DME patients, and all of a sudden उनमें नीचे आना शुरू हो गया, and a lot of them improved. And the key reason why it improves is the mechanism of action. So we know that all VGF, उन्होंने VGF A को ब्लॉक करना ही करना है, VGF B को ब्लॉक करना ही करना है. But the beauty of this molecule was कि साथ ही placental growth factor को भी ब्लॉक कर रहा था. And as research बढ़ती गई, पहले हमें पता होता था शायद एक ही VGF मॉलिक्यूल होता है, फिर पता चला उसकी भी 2-3 आइसोफॉर्म्स हैं. सो जो पहले मॉलिक्यूल्स थे वो उसी के आइसोफॉर्म्स को ब्लॉक कर रहे थे. एंड देन व्हेन दिस मॉलिक्यूल केम, देन वी फाउंड आउट कि देयर इज अ placental derived growth factor as well, there's a galactine molecule as well, and then the VGF ए की भी 2-3 फॉर्म्स हैं जो जिसके ऊपर ये जाके लगता है ए और बी उसको एंटी वीजीएफ के ऊपर. द अदर वंस वर ओनली ब्लॉकिंग ए. दिस हैड अ ड्यूल एक्शन. एक प्लेसेंटल ग्रोथ फैक्टर को ब्लॉक करता था और जो बी रिसेप्टर उसको भी ब्लॉक करता. एंड दैट वाज द रीजन इट वाज गिविंग दैट पंच. सो वी ऑल नो डीएमई के अंदर एंड एआरएमडी एंड रेटिनल वेन occlusions, these factors they are increased multiple times. So using this actually made sense in all those patients who were not being treated or who were not responding to previous treatments.
So probably that what the bevacizumab and ranibizumab could not achieve was probably because of those additional
things,
pathways that the aflibercept was targeting.
Yes, that was the reason.
Thank you, sir. So we'll move on. I'll request Dr. Amir Aman for his talk on the angiopoietin pathway, sir.
Sorry, what do you want to ask about? Thoughts
Sir,
on that? Okay.
Is the angiopoietin 2 pathway a relevant target for the treatment of exudative retinal disease? Is it effective if we target the angiopoietin 2 pathway, or is that relevant as we talked
I think we were
earlier,
discussing
yes, sir.
we were discussing briefly earlier as well. So first thing, as we know about aflibercept, that it acts at multiple action, at Qasim pointed it out as well. So it different receptors that it affects. So angiopoietin 2, again, we're not exactly sure. There are claims that there are few diseases. So here the factors shown mostly it's galactin 2, placental growth factors, VEGF A, B. So these all are getting inhibited with aflibercept. So other thing, we were touching about the angiopoietin 2, that how important it is. That does it definitely makes difference by blocking it, that can help to reduce the burden of disease or not. So there are certain factors where they say yes, that makes a difference, and there are others which say that doesn't make a difference. But other thing we discussed about is that angiopoietin 2 levels are also reduced in the vitreous, and that's shown in the rabbit model study. Aflibercept, ranibizumab, and bevacizumab, they all reduce it, and the maximum effect we can get with aflibercept, and that keeps maintained up till 56 days. So that's really effective in that case. So here it's they have shown. I think it's, yeah. So that's the thing they basically.
So there's this another thing that we have mentioned. We can see that if the VEGF levels are high, the Ang2 is relevant, but if they are low, it's of not very
That's the
significant
thing. Absolutely.
value. So if we are reducing the VEGF A levels, if we are inhibiting that, so would that be relevant? That is probably the question here. कि अगर ऑलरेडी वजफ को सप्रेस करने से आपका अगर वो चीज़ एड्रेस हो रही है तो इज इट वर्थ द एक्स्ट्रा efforts?
I think that's $1 million question because VEGF level, once it's get reduced, we know that the angiopoietin 2 levels also come down.
बिल्कुल.
So if the disease is getting affected by, so we are anyway reducing the angiopoietin 2 levels. So we don't know. So I think only thing Vabysmo, what I get is that what they claim is that up till 16 weeks duration. So that may be otherwise potency wise, the impact wise, I think aflibercept is
सर
very
जो
good.
जो ट्रायल्स हुए हैं दे हैव बीन
Yes,
नेक टू नेक, तो
absolutely.
इतना एफिकेसी में कोई
Absolutely.
इतना ज्यादा
There are no
फर्क
difference.
मोर और
Yeah.
लेस कभी कहीं एक अच्छा है कहीं दूसरा, लेकिन
Absolutely.
probably the deciding factor would
Yeah.
be
And same as I mentioned about the Avenue trial, it's about ranibizumab. So
Bilkul, sir.
ranibizumab was one of the older molecule, and we still see that it's the same effect. The visual outcome is same.
Bilkul,
Best
sir.
corrected visual acuity is same. It's not statistically significant at that time. But only thing is that here you have to give monthly.
monthly injection.
Whereas in Vabysmo, you can extend up till. But as we talked earlier, I think loading doses in the trials usually, mostly trials, what they do is they 5 loading doses they give. And Ali rightly pointed out, maximum I think what we give is 3 loading doses. We don't go beyond that. If somebody has got the good response, there is no fluid, we start extending. And we go up to 2 weeks, 4 weeks, we keep on extending, and if the patient maintains the response. And here I would like to mention, even with the bevacizumab, like I have got the patients in which I'm injecting at like 16 weeks. So
And he's still good.
yeah, they're
Still
good.
good.
So just they require, because the problem is that once you extend slightly more than that, they start developing the fluid again. So it depends on how the macular new vessels are and how chronic they are. But important, I think, message here for wet AMD is don't stop the injections, because one of my patient, I think I last time injected in 2017 6 vision he was maintaining. He came back recently with a vitreous hemorrhage, very dense vitreous hemorrhage, massive subretinal hemorrhages, subretinal scarring. So I did vitrectomy for him. Vision has come down to counting finger now, but it was 6.6. So at the other hand, I have got, like, I'm in Pakistan from 2013, so it's 11 years. One lady I'm injecting from that time, and before me, she was going to Khan. Dr. Azam was injecting, and that's her only eye. She's 6.6 vision. So now I have moved her to, and she's on Petizra, and moved up to 12 weeks. So ranibizumab, and she's maintaining good vision. So important question: wet AMD, never stop the treatment, because most of the new vessels are responding, and they require injections. If you are going to stop the injections, they are not going to. Only 1/3 lesions are in which you can stop the treatment.
Bilkul,
2/3,
sir.
yeah, you need to carry on.
बिल्कुल. AMD में sir, DME can
Yes,
they
DME
can
stop.
stay
DME,
for,
CRVO, central
बिल्कुल.
retinal vein occlusion, retinal 2 years. Yeah, you can
उसमें
stop
इतना
it.
प्रॉब्लम नहीं होता. वो कभी कभी साल 2 साल 3
Yes.
साल भी निकाल जाते हैं सर.
Because that's important. Yeah,
सर सर
I think that's they have shown
बिल्कुल
here.
वही सर
Yeah,
कि
the weakest levels, yeah.
with all the other anti-VEGFs, the Ang2 levels are reduced. So the point we were trying to
Yeah,
make, sir.
and that was, I think, new Nesvecumab.
Yes, sir.
What they used in Onyx and Ruby trial, and what they found, it was more potent,
Yes, sir.
but they didn't notice any difference. They combined with
Bilkul.
aflibercept and just a monotherapy, and they didn't notice any difference at all. Which I think that was the reason they didn't proceed further.
बिल्कुल सर.
At that
ऐसे ही
time,
सर,
so
क्योंकि it is a cancer drug, and they used it on a trial, but
Yeah.
they did not get any results, sir. These are the, sir, Ruby and
Yeah.
Onyx trials that they did, and they did not show any additional benefits in vision or central retinal thickness. Sir, the Avenue trial.
Yeah, that's the
that
same
you
one,
talked
Avenue
about.
one, which we're talking about.
Thank you, sir. Thank you very much. Dr. Ali Afzal Bodla, sir. Comparison of loading dose between aflibercept and faricimab for a neovascular age-related macular degeneration. Sir.
Well, the first thing that we have to look in any trial, as we are going to have a look at this particular trial, is loading doses, number of loading doses. एक जो बहुत बड़ा problem है बेशुमार trials का, the loading doses are not the same, because this is what which has been recommended by a particular pharmaceutical, and we are following that particular pathway. Now, if one of your patient has got 3, for example, aflibercept injections, as compared to the other one who has got 5 aflibercept injections as a loading dose, obviously the 5 one is going to do better.
Bilkul.
There is no debate about it. So this is the Japanese one, isn't it, that we
Yes,
are
sir.
talking about? So I think in this particular trial, what they have done is they have kept the number of injections same, if I'm not wrong. So they have compared a loading dose of 3 injections as compared to a loading dose of 3 injections.
Bilkul.
So this is a good thing because it gives us a kind of real-time information. The number of patients, obviously, it's not a very large group that we are talking
Yes, sir.
talking here. Like we are looking at 30 patients here, and all of them are from the same ethnicity. So again, it's just a Far Eastern population we are talking about. It's a retrospective data collection, and it has been done in Osaka. So yeah. And I think the loading dose, yes, as I was saying, it's the same loading dose, 3 for aflibercept, 3 for fari. And the results, I believe, were that I think the visual acuity was slightly better.
Sir, they did this study because in the previous studies it was the loading dose was different,
Yes.
the intervals were different. In this study, they did exactly the same for both the drugs.
Okay.
For the same for faricimab and for aflibercept, and they found out that the visual, the improvement in the retinal thickness was good in both, but the visual improvement was better with aflibercept, sir. It was not too significant in faricimab, as we discussed
Yes,
yesterday.
we
sir.
did, we did.
Yes, sir.
Okay.
So, but again, as you said, the sample size is a bit small.
Yes.
And
But I think it's a good real-time observation for us
observation,
as well,
yes, sir.
that at the moment, whatever we are getting with the same number of injections, aflibercept is doing well.
yes, that is the point.
So yeah, this is the point that this particular study suggests. So yes, and I think they have given like there is a certain degree of difference between the values that we have got with faricimab
Yes,
and
sir.
what we have got with
Yes,
aflibercept.
sir.
So yeah,
vision
we are
wala.
looking at 0.4 here, 0.0047, and then 0.60. So obviously, it seems to be statistically significant with aflibercept.
Yes, sir. CRT was more or less the same, sir.
Okay, I think probably like if you look in the paper, if you look in this particular paper, aflibercept has done well,
Yes,
and we hope the same for time to come. But the real world is going
Yes,
to
sir.
give the answer in future.
A trial is one thing, and what really matters is your personal experience and real world data that comes out, and then you decide actually what really happens on
Yes.
ground, sir.
Yes, that is very true.
That is very
And
relevant.
just extending the Amir's point, because we are talking about neovascular AMD here. Now, when we are planning something, I think pretty much we are planning for life of the patient when it comes to neovascular AMD.
Very good, sir.
So there are so many things that you should be taking in account for. It doesn't matter whether that patient continues with you or with one of your colleagues.
But he
that
has
is
to.
absolutely fine, obviously, but it has to. So a lot of question comes in, and many times when you are taking such decisions, your decisions are based on the time and tested things that you have experienced, which at the moment, for us at least, is aflibercept.
Right.
So we'll see how it goes.
Sir. So, in conclusion of the study, both were effective in reducing exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve visual acuity. So, third was कि exudative changes उसने कितना उसमें effect आया. तो वो चीज़ उसमें काफ़ी उन्होंने सर
जी, to be
fluid levels और वो सारी चीज़ें वो all that.
हकीकत ये है कि I think probably we just know 5% of the whole mechanisms involved in this particular pathology. Like we are far away. There are going to be new things. There are going to be new explanations. So this is what we are looking for.
Thank you, sir. Sir, Dr. Khalid Wahid, sir. So you came a bit late, sir. We didn't have मौका नहीं मिला सर आपसे एक्सपीरियंस लेने का.
Well, we've heard the speakers talk about this magical injection. We, Eylea is an injection we all trust. Eylea is an injection we have all tested, and it has, helped us where we have got stuck in the past. We all know that it is effective in all sorts of retinal leaking retinal conditions, may it be wet AMD or vein occlusions or diabetic macular edema. Obviously, you've now got a competition ahead. When we talk about Eylea in the context of Pakistan, up till now, obviously, all the speakers, including myself, we have great experience with Eylea injection, and the new injection, faricimab, has just come into Pakistan, and obviously we're all injecting. We do not know how effective it is going to be in the long term. It is giving us reasonable results at the moment, but and we also know that in the West it's giving great results. Cost is an issue in our country, and it's a big issue, and from that point of view, I have to say, your injection obviously is much better priced compared to faricimab. As Amir was mentioning, the big plus of faricimab is the treat and extend thing. And yes, I agree with Amir that in a lot of my patients with wet AMD, I have been able to extend till 16 weeks, 12, 16 weeks. And I also agree with Amir on this, that wet AMD patients their treatment should never be stopped. Right. They should always have an OCT, even if they are stable, and they should never be left untreated. With the diabetic macular edema, I have noticed, in the past, since I was also working in, government hospitals, so a lot of Avastin was being used there for diabetic vitreous hemorrhages and diabetic macular edema. And the big difference I noticed between Avastin molecule and Eylea was, I thought that Avastin was making the vitreous very rigid. As a vitreoretinal surgeon, I noticed that, patients who had advanced diabetic eye disease, their, multiple Avastin injections were increasing the fibrous activity within the vitreous, within the vitreoretinal sector. And the second thing I noticed with that injection was the anatomical success of Avastin did not sort of complement with the vision. So even if we had a flat, a macula which looked completely dry, the vision was not complementing. So I think, another thing which I wanted to mention today was that we look into the central macular thickness and various molecules and how effective this molecule is in reducing the macular edema. We also need to look into the functional part, that whether with this injection, with a central corneal thickness of, say, 300 or 280 achieved by Eylea or Vabysmo, what is the vision like, right? Because, that's very, very important. I don't think I need to add anything else. I mean, it's a great molecule, and for, our country, cost effectiveness is very important, and I would tick all the boxes when it comes to an intraventricular injection case of Eylea.
Thank you, sir. So you mentioned that you have started using Vabysmo in the recently. So were they treatment naive patients, or did you switch from another drug, or what was the motivation behind shifting to?
Well, I have to say there were certain patients who were resistant to all sorts of previous anti-VEGFs, and so yes, there's one big category of patients who were shifted to Vabysmo. Sorry, wet AMD as well as DME patients. ہاں نہیں اگر دیکھیں اگر آپ اس کا OCT کرتے ہیں اور OCT
is normal, vision stable.
تو پھر آپ ایکسٹینڈ کر سکتے ہیں اس کو منتھلی اس کو ریویو کریں OCT ریپیٹ کریں اگر آپ
So when there's change in the OCT or change the vision, you
vision
inject.
or yes, both are
So
important.
it's not the time. It can be more than 40 months or 42 months.
That never happens.
Injected macular degeneration.
Yes, but as you said in your talk, in your message, that we should not only go by the central macular thickness.
It's the vision.
Vision is very important. Patients already know when they have a leakage. They would come to you saying that they feel that they are a bit worse. So yes, at that point, I think even if the OCT looks very similar, you should have a low threshold to inject.
یہ جو ٹریٹ اینڈ ایکسٹینڈ ہے نا, یہ جو نئی ڈرگس آئی ہیں کہ نمبر آف انجیکشنز کم ہو جاتے ہیں. اف یو ان کی اسٹڈیز ڈیٹیل میں دیکھیں, دے ور 141 ان لسرین, اس میں سے 15 پیشنٹس تھے جن کو یہ ایکسٹینڈ کیا. ان 129 اور 128 پیشنٹ دے ور ریگولرلی ہیونگ دا ڈرگ ان ایج ریلیٹڈ میکولر ڈیجنریشن. تو یہ آئی تھنک پروموشنل اسٹنٹ ہے کہ ایکسٹینڈ کریں, ہم کریں, ادروائز دے نیڈ دا ٹریٹمنٹ ریگولر بیسس. So because when we discussed with this Facimab کے وہ لوگ آتے ہیں کہ جی اتنے مہنگا کیوں کیا ہے, اس کے یہ کریں جی ہمارے میں یہ ہے. You should read the literature and then answer them کہ آپ نے اتنا مہنگا کیوں کیا ہے. جو آپ کہہ رہے ہیں it's not right. اگر 141 میں سے صرف 15 پیشنٹس کو ہم نے ایکسٹینڈ کیا ہے, ان میں نمبر آف انجیکشنز کم ہوئے ہیں, تو باقی جو 126 تھے ان میں تو ریگولر لگتے ہیں, ان میں تو کوئی بھی کم نہیں ہوا.
جب بھی کوئی نیا مالیکول آئے گا, نیا انجیکشن آئے گا, وہ بہت کچھ کلیم کریں گے, بیکاز یہ ایک اسٹیبلشڈ انجیکشن ہے جو کہ یونیورسلی ایکسیپٹیڈ تھا اور ہے. تو if some new injection has to market itself, it will certainly say that this is our plus.
And they're picking up the things جو ان کے لیے ہے. انہوں نے یہ نہیں دیکھا کہ ریٹنل سیلس کو کون ڈیمیج کر رہا ہے زیادہ, سسٹیمک ابزارپشن کس کی زیادہ ہے, اس کو تو ایڈریس ہی نہیں کرتے. کسی ایڈریس کرتے ہیں کہ جی ایڈیما کم ہو گیا, وہ کم ہو گیا, نمبر آف انجیکشنز کم ہو گئے, صرف یہ پوائنٹ ہے. ادروائز ریٹنل سیلس کو دیکھیں.
کافی پیشنٹس ہیڈ ٹو گو بیک. اس میں ابھی ایگزیکٹلی مجھے نمبر بھولا ہے, لیکن اٹس سم ویئر اراؤنڈ 30-35% کہ جو 12 پہ گئے ان کو واپس 8 پہ آئے. اور کافی اس طرح نہیں ہے سر کہ
I mean literature people shifted to ranibizumab and then Eylea, and then Eylea کو response نہیں آ رہا تھا, they came back to Petrozra, اس میں response آ گیا. So it's a very عجیب سی چیز ہے جو we have to study, think and titrate each patient accordingly and not follow these the business stunts.
You're absolutely right.
Personally,
in diabetes, supposing we are dealing with a bad diabetic, right? That patient's macular edema depends upon so many other factors. Systemic control is important. Diabetic systemic control, hypertension, kidney functions. These are all factors that are going to make his macular edema worse. So no matter what you inject, if these aspects of his health are not covered, no injection is going to be as effective. So yes, you are absolutely right. It should be the choice of intravitreal injection should be titrated according to the patient's needs.
یہ جو ہے کہ 6 ٹیکے لگا دیں ڈائبیٹکس میں اسٹریٹ اوے نان اسٹاپ, اس کی ڈائبٹیز کو ایڈریس ہی نہیں کیا. آئی تھنک یو ٹائٹریٹ دا ڈائبٹیز 6.5 پہ لے کے 3 کے بعد اس کو ضرورت نہ ہو, لیکن اگر 6 کے 6 لگا دیں, بعد میں آپ کا پیشنٹ آتا ہے کہ نہیں آتا. it's
ڈائبیٹکس کا
more of
بہت
a
بڑا
you have to
ایشو
think
ہے
about
ہمارے
it.
ملک میں.
سر جنرلی ہمارا سر یہ اس ایسپیکٹ میں ہم بڑے ویک ہیں سر کہ اب ہمارے پاس جیسے سر آپ کہہ رہے ہیں کہ اس کا شوگر ہمیں پتہ, تو وہ جو بیس لائن انویسٹیگیشنز آئی تھنک دیٹ شوڈ بی مینڈیٹری کہ اس کا لیبر پروفائل, اس
ہمارے
کا
ملک میں نہیں,
HbA1c.
اٹس ورلڈ وائڈ. میری کل اثر سے بات ہو رہی تھی, اسٹیٹس میں بھی بات ہو رہی, اٹس ورلڈ وائڈ, پیپل ڈو ناٹ کنٹرول their diabetes.
کیونکہ وہ سر پھر سم ہاؤ ایٹ لیسٹ فار می آئی فیل گلٹی جب وہ مریض ٹھیک نہیں ہو رہا ہوتا تو پھر آپ تھوڑا سا اس کو ڈگ ان کریں تو
یہ جو انجیکشن ہے نا, جو اتنی پرائس ہے, اٹ ہیز ڈیول افیکٹ. ایک تو وہ ریٹنا کو ٹھیک کرے گا, ایک تو پیشنٹ کو بھی کہے گا جی وہ میاں صاحب بیٹھے ہم وائف کے ساتھ یا تو شوگر ہی کنٹرول کر لے تو ٹیکے تو لگوانے پڑیں گے. سو دیٹس آلسو فیکٹر کہ جی پیسے بھی لگ رہے ہیں کہ میں شوگر کنٹرول, اینڈ پیشنٹ اب وہ کرتے ہیں کہ مجھے ٹیکے نہ لگوانے پہ میں ڈائبٹیز کنٹرول. آئی سین پیشنٹ فرام 10 11 دے کم ٹو 6.5. اس میں کہتے ہیں دو بندوں کا قصور ہے, آدھے آپ کا ڈاکٹر ٹھیک نہیں یا آپ ٹھیک نہیں, اینڈ میکسیمم پیشنٹ کہتے ہیں ہم ٹھیک نہیں, آم کھا لیتے ہیں, چاول کھا لیتے ہیں, وی ڈونٹ کنٹرول. جب ان کو انجیکشن لگے اتنے مہنگے 3-4 لاکھ لگ گیا تو ناؤ دے کم ٹو 6.5 ڈائبٹیز اینڈ از کنٹرول, یو ڈونٹ نیڈ اینی مور انجیکشن.
سر بڑا افیکٹ آتا ہے, یہ ایسے نہیں ہے کہ نہیں ڈائبٹیز کنٹرول ہو, آپ کا کولیسٹرول لیولز اور وہ ساری چیزیں ٹھیک ہوں,
And another, I don't know, I would like these panelists to discuss about the central vein occlusion. یہ پیشنٹ کو بھی ہم وہ آتے ہی رہتے ہیں,
بالکل
ٹھیک ہو گئے پھر آگے, ٹھیک ہو گئے پھر آگے, حالانکہ ان کی ڈائبٹیز بھی کنٹرول ہے, بلڈ پریشر بھی کنٹرول ہے, اینٹی اس پہ پلیٹلیٹ پہ بھی ہیں. I don't know scenario. Can anyone tell me about that? Vein occlusions کا.
وین اوکلوژنس جو ہے ایک بالکل ڈفرینٹ چیپٹر ہے, عامر بھی اس پہ شاید ہمیں ان پٹ دے سکے. I actually I use a combo therapy for vein occlusions, so I usually give them posterior subtene on steroid, and I give them an intravitreal anti-VEGF, and I think
I do the same thing.
Sorry?
I do the same.
Yes. So, most of us, know how to, vein occlusion is a different category. So, you have to give them steroids, not with every sort of anti-VEGF, maybe, give, if they are getting 3 intravitreal injections, then first one you do a combination, and maybe the third as well, give it a miss on the second one. So, yeah, but you're absolutely right. They keep coming back.
Vein occlusions,
and the other thing with vein occlusions is their visual prognosis is not very good. Somehow, they have ischemic changes in the retina as well. Obviously, that's one of the reasons why
I
they
think
are.
wide angle جو ہے نا FFA is very important.
Yes.
اس میں کروا کے ischemic area کو ابلیٹ کریں, and I think that it does work. لیکن پھر بھی وہ PRP کے بعد بھی, لیکن وائڈ اینگل از مسٹ.
آپ نوٹ کریں کہ ان کو آپ جب وہ ڈرائی بھی ہو جاتے ہیں, کمپلیٹلی ڈرائی بھی ہو جاتے ہیں, تو ان کی ویژنز نہیں امپروو کرتی
بیکاز آف the damage to the retinal cells.
سر کبھی آپ نے وہ ٹرائی کیے سر, یہ جو آپ کامبو بات کریں فرسٹ وزٹ پہ انسٹیڈ آف PST کے, اگر آپ سپراکروئڈل, بیکاز آئی ہیو ہیڈ ویری گڈ ریزلٹس ود سپراکروئڈلس.
جی بالکل سپراکروئڈل کا بہت اچھے ریزلٹس ہیں. یس, پیپل کین وی کین آل ٹرائی سپراکروئڈلز ایز ویل. That's the point. Yes. I mean, suprachoroidal can have equally good, if not sometimes in certain cases better outcome, but the stakes are slightly higher. It's slightly more risky. So in a patient who's already having an intravitreal injection, I would rather keep myself away from the choroid and do a posterior subtene. So that's my choice. I would welcome any other suggestions.
I would like to add کہ جو ڈائبیٹکس کیسز ہیں نا, ان کی لیئر بائی لیئر ڈفرینس ہوتی ہے بٹوین ہیومنس. آئی مین اٹس ناٹ لائک ایوری ڈائبیٹک پیپل ایڈیما از ون انڈیویژل از سیم ٹو another individual. You see ischemia, I mean some of the cases will be having 10% ischemia, 90% exudation. Some will be having different percentage. اس کے علاوہ اس میں جو ایلپسوئڈ لیئر ہے اس کی افیکشن کتنی ہے, اس میں ڈرل کتنا ہے, تو رسپانس کی جو ڈفرینس ہے وہ انڈیویجولی ویری کرتا ہے. سو یو ہیو ٹو انڈیویجولائز یور کیسز.
بالکل سر.
ہاں, ریگارڈنگ دی ادر تھنگ, آئی ایم انجیکٹنگ suprachoroidal for the last 5 years. I have not injected any intravitreal times in alone in the last 5 years. اور یہ سب چیزاں تو وی نیور یوزڈ اٹ, بٹ آئی ایم ویری ہیپی وتھ سپراکورائڈل.
بالکل سر.
ٹرانزینٹ آئی او پی رائز انیشیلی ہوتا ہے, but in the long run I think it's much safer treatment modality to my
0.1 ہی لگاتے ہیں سر, 0.1 لگاتے ہیں.
0.1 یا 0.05.
سر جو بس میں اس کو میں صرف 0.1 کے ساتھ I had a lot of problems آئی او پی والے اور اس طرح. when I shifted to 0.05 I have never had a problem sir.
We usually inject 0.05.
ہاں 0.05 سے ریزلٹس اچھے ہیں, اور وہ جو آئی او پی اور وہ جو سارے پرابلمس ہیں they have improved a lot sir. Sir, Dr. Tariq Khan sir, how FDA review?
Yeah, I think you have sent me this study. FDA has reviewed all this جو ان کے درمیان میں پرابلم ہے بیکوانٹ فیسی میپ اور یہ کہ کون سچا ہے کون جھوٹا ہے. ٹھیک ہے, تو دے ہیو کم اپ ود, پہلے انہوں نے کہا دس superior than aflibercept, and then they have said no, it's not superior, non inferior, is equivalent to that. And there's no role of NG2 in the treatment and combining with anti-VEGF. یہ FDA کی results ہے which have come up with that summarize. باقی وہ I think we should always read, all these studies are available on the internet. ان کو study کریں, discuss with the people who are coming to you for the promotion of the product. وہ بھی پڑھ کے آئیں, then you study and then you decide, and then the patient is on top of the list. آپ نے اس کا بھلا سوچنا ہے نہ کہ کمپنیز کا. That is my advice to all. Thank you.
سر یہ وہ ساری جو
ہاں وہی آپ نے پہلے بتایا نا ایکول تھا, ان کو 4 ان میں دیے, 3 ان میں دیے. سو جب برینی بیور شروع میں آپ کے آئے کمپٹیشن, ہمیں دبئی لے گئے مور فیلڈ میں, انہوں نے کہا جو اسٹڈیز ہوئی ہیں ان میں کیا فلاز ہے. سو آل دا اسٹڈیز دے ہیو فلاز. وہ اپنے کو کہتے ہیں ہم نے بہت اچھا کیا, یہ اسٹڈی وہ اسٹڈی کی, لیکن جو کانٹریکٹ کرتے ہیں ان میں فلاز وہ نکال ہی لیتے ہیں. اٹس لائک میڈیکل ایجوکیشن, ڈیفیکلٹ ٹو انڈرسٹینڈ, ڈیفیکلٹ ٹو نو. تو فلاز تو ہوتے ہیں, دے ٹائٹریٹ اکارڈنگ ٹو دیئر اون بینیفٹ. انہوں نے کہا $1 million question is $1 billion question, کیونکہ $1 billion are being spent or earned. So I think we should be very careful in the treatment of patients, especially in our part of the world where there is no insurance. اب بعد بھی انشورنس کرنا فل کور تو کرتی نہیں, وہ اتنے ڈالرس اس نے دینے. I can tell you, my friend came from state, Lubingen eye drops, insured بھی ہے patient, they have to give $50.
پھر بھی
ہاں اگر ان کی انشورنس نہیں ہے $700 فار 1 bottle of Lumigan, جو یہاں 1400 کی مل جاتی ہے. سو سی کیوں, آئی مین واٹس دا ڈفرنس, وہاں پہ کیوں مہنگی, یہاں کیوں سستی ہے. تو یہاں پہ جو سستی بیچتے ہیں Lumigan, وہ اپنے آپ کو نقصان میں تو نہیں کر رہے.
وہی سر وہ $1 million question میں یہ بھی
$1 billion انڈسٹری, $1 billion آف انڈسٹری, ٹرمپ کو کرے, بائیڈن کو کرے, اسپورٹ از آل ان کے پیچھے ایک ہوتا ہے. سو وی ہیو ٹو بی کیئرفل. Thank you.
Very true, sir. Sir, we have discussed all this. یہ پچھلے آدھے پونے گھنٹے میں سر یہ ساری باتیں ہم نے ڈسکس کی ہیں کہ جو ہمارے انیشیل لوڈنگ ڈوز میں فرق تھا, اسٹڈی ڈیزائن میں فلاز تھے, تو اٹ از آل دیٹ. تو وہی جیسے سر آپ نے کہا, اسٹڈی ڈیڈ ناٹ ڈیمانسٹریٹ سپیریورٹی آف فیریسیمیب اوور ایفلیبرسیپٹ بٹ انسٹیڈ ڈیمانسٹریٹڈ نان انفیریورٹی آف فیریسیمیب.
یہ پڑھ لیں گے لوگ جا کے
سر,
میرا خیال ہے کہ یہ لوگ پڑھ لیں گے. تو مجھے خیال آ رہا ہے کہ 2 منٹ باقی ہیں, تو اب تم ہی بتلاؤ کہ ہم بتلائیں کیا 2 منٹ میں. لیکن listening to all the honorable members of for injecting, اگر ہم ریئل بات کریں تو آپ یہ دیکھیے گا کہ ہم 2 چیزیں فالو کرتے ہیں, سیفٹی اینڈ ایفیکیسی. یہ ہمارا کام نہیں ہے, ہمیں بتا دیا گیا ہے اور ہم اس کو بغیر سوچے سمجھے لگا رہے ہیں, اس لیے اس کا کوشچن ختم ہو گیا. ہمارا جو امپورٹنٹ کوشچن ہے دیٹ از کاسٹ, یہ تو امپورٹنٹ بات ہے. سیکنڈلی آپ دیکھیے گا کہ جو اسٹڈیز یہ پیش کی جاتی ہیں اس میں کہا گیا کہ 90% سکسیس ریٹ ہے فار ایگزامپل, لیکن وہ 90% تب سکسیس ریٹ ہوتا ہے جب وہ 140 یا 240 پیشنٹس دے آر ریگولرلی کمنگ ٹو دی کلینکس جہاں پہ اسٹڈی ہو رہی ہے. ہمارے یہاں پرابلم یہ ہے کہ ہمارا جو ریئل سینیریو ہے اس میں ہمارا پیشنٹ اتنا ریگولرلی نہیں ہوتا, اس لیے وی کین ریچ ٹو 90%. جو 4 لائنیں بڑھ گئی ہیں, 5 مائکرون کم ہو گیا, وہ ہمارا نہیں ہوتا بیکاز کہ وہ سارے پیشنٹ ہمارے ساتھ اس طرح فالو اپ پہ نہیں ہیں. ایک کوشچن اور ڈیولپ ہو رہا ہے جو بھی بات کر رہے تھے عامر, لوڈنگ ڈوز کا کانسیپٹ ہے. اچھا, اب یہ ہمیں کسی نے نہیں بتایا اسٹڈیز نے, یہ ہم پہ پش کر دیا گیا اور ہم نے بلائنڈلی فالو کر لیا, اور اتنا بلائنڈلی فالو کیا کہ ہماری آنکھوں نے میکولر ایڈیما ان کیس آف ڈائبٹیز میکل ایڈیما دیکھنا چھوڑ دیا ہے. دوبارہ بول رہا ہوں میں آپ کو بات, ہماری آنکھوں نے میکولر ایڈیما دیکھنا چھوڑ دیا ہے. پیشنٹ کا پرسپیکٹو بالکل یہ نہیں ہے کہ سی آر ٹی کتنا کم ہو رہا ہے, ہیمریج کتنا کم ہو رہا ہے. پیشنٹ کا صرف ایک ہے کہ ویژن بہتر ہو رہی کہ نہیں ہو رہی, اور ڈاکٹر بڑا خوش ہو رہا ہے کہ او سی ٹی میں کمی ہو رہی ہے. اب کوشچن یہاں پہ کیا آیا کہ اگر ویژن بہتر نہیں ہو رہی, اب یو ہیو انجیکٹڈ 1 انجیکشن, ویژن بہتر نہیں ہوئی, تو کیا آپ کی آنکھیں دیکھ رہی ہیں کہ ایڈیما بہتر ہوا ہے؟ نہیں دیکھ پا رہی, یا آپ کو شک ہے تو پلیز گو فار اے 3000 OCT rather than for 60,000 injection. Maybe there is a possibility there is no fluid now and the reason of less vision is something else. That may be photoreceptors, that may be something else جو آپ نے پہلے شاید نہیں دیکھی. تو اسکیمیا, تو میرا ماننا یہ ہے کہ ہم ایفلی برسیپٹ لگا رہے ہیں آج کل, ایفلی برسیپٹ سے ہم لوگ خوش ہیں آج کل. That is giving a very quick resolutions, that is giving a somewhere cost effectivity as compared to Petizra. اگر اویسٹن بند نہ ہوتا اور پیٹیزرا اوپر نہ جاتا تو شاید ہم ایفلی برسیپٹ نہ لگا رہے ہوتے. ہم یہ کہتے ہیں کہ ہم یہ بہتر لگا رہے ہیں, ہم نے فیل کیا ہے کہ یہ بہتر ہے کیونکہ ہمارا یہ مینٹل امپریشن ہے. لیکن ابھی بھی ہمارے یہاں پرابلم یہ ہے کہ ہم لوڈنگ ڈوز کے کانسیپٹ لگاتے چلے جاتے ہیں, اور جس طرح ابھی کیا نام ہے عزیز بتا رہے تھے, مجھے تو تکلیف ہو جاتی ہے جب دوسرا انجیکشن لگانے کہنا پڑے کسی پیشنٹ کو جی 60,000 اور لے کے آؤ. اور صحیح بات یہی ہے جو طارق بھائی کہہ رہے تھے کہ ہم کبھی بھی فالو نہیں کرتے کہ وہ پیشنٹ جس کا ہمیں افیکٹ نہیں مل رہا, کیا اس کے HbA1c, اس کے رینل پیرامیٹرز, اس کے کولیسٹرول پیرامیٹر نیچے آ رہے ہیں. وہ پھر بھی 3 آم کھا لیتا ہے اور 2 دن پہلے گلوکوفیش کھا کے شوگر 120 دکھا دیتا ہے اپنے بیٹے کو, لیکن اس کا سی آر ٹی بڑھتا چلا جاتا ہے. تو میرا خیال یہ ہے کہ بینگ دی ریٹنل سرجنز ہمیں جو فوکس کرنا چاہیے وہ یہ کرنا چاہیے, ایک تو اپنی آنکھوں پہ یقین کریں کہ آپ کے ایڈیما نظر آ رہا ہے. سیکنڈلی ہمیں 60,000 کی بجائے ہم یہ کہتے ہیں یہ بڑا مہنگا ہے OCT 3,000 کا, ہم وہ نہیں کراتے, 3 مہینے کرائیں گے, یہ ہماری پریکٹس ہے. وہ ہمیشہ ہونا چاہیے. اگر آپ انجیکشن 60,000 کا لگا رہے ہیں تو بہتر 3,000 کے OCT کرا لیں. اور تھرڈلی پلیز, ہمارا جو پرابلم ہے ہماری جنریشن کا, ہمارا پرابلم یہ ہے کہ ہم آج بھی یہاں بیٹھے ہوئے بینگ دی آفٹھلمولوجسٹ ہم شوگر کنٹرول کے اوپر بالکل فوکس نہیں کرتے, اور یہی وجہ ہے کہ ہمارے پیشنٹ دن بدن کی فائلیں بڑھتی چلی جا رہی ہیں اور ان کا ویژن بھی کم ہوتا جا رہا ہے. آخری بات کرنا چاہ رہا ہوں جو ہمیں سمجھنی چاہیے, جو میں ایک میسج دینا چاہتا ہوں جو لوگ بیٹھے ہوئے, ٹریٹنگ ڈائبیٹک پیشنٹ, ٹریٹنگ AMD پیشنٹ از اے کانٹریکٹ. یاد رکھیے گا, جب یہ ہمیں کہہ رہے ہیں کہ ہم نے پیشنٹ کو فالو کیا 1 سال 2 سال 3 سال 4 سال 5 سال 6 سال, تو آپ اپنے پیشنٹ سے بات کیوں نہیں کرتے کہ بھائی اگر تم مجھ سے ٹریٹمنٹ کرانی ہے تو یو ہیو ٹو بی اے کانٹریکٹ ود می فار 5 years ایٹ لیسٹ. میں کیسے بتا دوں گا آپ کو, آپ انجیکشن لگائیں 2 مہینے غائب ہو جائیں پھر دوبارہ آ جائیں, میں کیسے کہہ سکتا ہوں کہ آپ ٹھیک ہو رہے ہیں؟ یو ہیو ٹو بی اے کانٹریکٹ تاکہ آپ اس کو لوڈنگ ڈوز OCT کر کے بتا تو سکیں کہ آپ بہتر ہو رہے کہ نہیں ہو رہے. اگر وہ کانٹریکٹ میں نہیں ہے, چاہے وہ AMD پیشنٹ میرا ہے یا آپ کا ہے, ہی از ناٹ اے بیٹر پیشنٹ, ہی ول ناٹ بی ٹریٹڈ. آپ بے شک روزانہ انجیکشن لگائیں, آپ چاہے 19 میں سے 200 میں سے 19 کو لگائیں, اگر وہ کانٹیکٹ میں نہیں ہے, اگر ڈاکٹر چینج کر رہا ہے تو ہی وڈ ناٹ بی اے ہیلدی پیشنٹ اینی مور. تو میرا یہی ہے کہ ایفلی برسیپٹ از ناٹ اے گڈ ڈرگ, ہمیں اچھا مل گیا ہوا ہے, لیکن اس کے ساتھ ہمیں تھوڑا فوکس کرنا پڑے گا OCTs کے اوپر بھی, ہمیں فوکس کرنا پڑے گا سسٹمک کنٹرول کے اوپر بھی, ہمیں فوکس کرنا پڑے گا کانٹریکٹ کے اوپر بھی. ہمارا کانٹیکٹ ہونا چاہیے, یہ کانٹیکٹ ڈلیوری ہے, ادروائز نہیں ہو سکتی. میرا خیال ہے یہ. تھینک یو ویری مچ.
تھینک یو سر.
غلط ہی ہے نا, اور پرابلم یہ ہے کہ میں آپ اس کو اپنے ہاتھ میں ہاتھ رکھے دل پہ, آپ کی آنکھوں نے ڈائبیٹک میکل ایڈیما دیکھنا چھوڑ دیا ہے. پوچھ لیں اپنے آپ سے, آپ پیشنٹ آتا ہے OCT کرا لو, OCT دیکھا موٹا تھوڑا پھلا ہوا ہے, یہ بھی نہیں دیکھا کہ جو پھولا ہوا ہے اس میں اسپانجی پیٹرن ہے, سسٹک پیٹرن ہے, فوٹوریسپٹر کیسے ہیں, ERM کیسی ہے, VMT کیسی ہے, RP دیکھتے بھی نہیں ہے. اس طرح سے اوپر سے وہ بنا ہوا گندا سا, एक और टीका, फिर गंदा सा टीका, और ये भी 3-3 महीने के बाद आपकी आंखों ने एडिमा देखना छोड़ दिया. नो डाउट दुनिया ये कहती है आजकल कि हमारी आंखें ओसीडी से बेहतर नहीं देख सकती, कहती है दुनिया इस पे आ गई है कि आंखें ओसीडी बेहतर नहीं देख सकती, लेकिन कम से कम ओसीडी कराओ तो सही ना, कोई और रीजन तलाश करो विजन कम होने की. मरीज खुश नहीं है, 3 टीके लग गए, मरीज को विजन बेहतर और उसके फोटोसेप्टर उड़े हुए हैं. और यही क्वेश्चन जब हम पार्ट 2 में बच्चों से पूछते हैं उनको पता नहीं होता, क्योंकि हम ये ना हम करते हैं ना सोचते हैं बोलते हैं. तो ये है. थैंक यू.
I think the time is low because we have another 12:30 बजे PVR की मीटिंग है जिस पे इलेक्शन का भी होना. तो
Sir, I would like Dr. Nasir Saeed to conclude the session, sir.
थैंक यू वेरी मच. बाकी तो सब लोग बोल चुके हैं हर चीज़ पे, और मैं थैंक्स कहूँगा बायर को कि ये मीटिंग अरेंज कराई, और इतने सारे जो एक्सपर्ट्स इधर बैठे हुए हैं उनकी सारी की हमने फर्स्ट हैंड एक्सपीरियंस को सुना. तो आई थिंक जो विट्रो रेटिनल स्पेशलिस्ट नहीं है तो उनके लिए एक बहुत अच्छा वो था एक्सपीरियंस. थैंक यू वेरी मच.